Good evening, all. Firstly, wishing all of you a very Merry Christmas and a Happy New Year in advance. Today is going to be the last journal club for this year 2025. And for this particular journal club, we are going to have two very relevant articles which are going to be discussed. The first one, the journal club article, is going to be a sequential therapy of talquetamab as a bridge to CAR-T therapy. Now, we all understand when we take up patients in relapsed refractory myeloma for CAR-T, the biggest trouble that most of us face is that the patient is in a relapse situation, there's a heavy load of the disease, and when we take up such patients for immunotherapy, the chance of having CRS or various other immunotherapy related complications like cancer and everything would be very high. So we all would love to bring down the load of the disease, and currently the teclistamab that we have, the bispecific, only bispecific that we have, we cannot give it because that would decrease the effective targets. So what shall we do as a bridging? Many of us resort to high-dose chemotherapy, but this article would talk about targeting GPRC5D bispecific antibody talquetamab as a bridge to CAR-T. So we have Dr. Akash Jha from AIIMS Jhajjar, who is going to present and talk about this particular article. Thereafter, for the journal scan, we are going to have the first or the largest relapse refractory data from the country by none other than Professor Lalit sir. So sir is here as the national expert also today, and we would hear from the horse's mouth about the relapsed refractory myeloma in India. So welcome Lalit sir. So he requires no introduction to the August gathering or the audience that we have today. He is a well-renowned entity in the country. He has put myeloma on the international map from India. So we welcome you, sir, for this particular event, and we thank you for accepting the invitation as a national expert. And with that, without further ado, I would like to hand over the stage to Dr. Akash for presenting the Journal Club article on the talquetamab before BCMA CAR-T. Also, we have with us today Pankaj sir, the past president and the current HOD of clinical hematology and medical oncology from PGI Chandigarh. So we have two renowned people here to discuss the nitty-gritties and threadbare about these two articles. So over to you, Dr. Akash, for presenting the article. Thereafter, once he completes the presentation, we would get back to Lalit sir and Pankaj sir for their comments, and then any comments from the audience. And thereafter, I will hand over to Sumit for conducting the journal scan. With that, over to you, Dr. Akash, please.
Good evening, everyone, and Merry Christmas to all. So today we have gathered here to discuss a very important topic, and this paper is published in Blood in October 25, and the title is Sequential Targeting in Multiple Myeloma, Talquetamide GPRC5D bispecific antibody as a bridge to BCMA CAR T cell therapy. So what are bispecific antibodies? Bispecific antibodies are basically antibody constructs which have two binding sites. One attaches to the tumor cells, another to the immune effector cells. This way, E cells are activated and then they kill the tumor cells. So if you see till now, there have been multiple targets that have been exploited in manufacturing of bispecific antibodies. Mostly these are BCMA, most commonly. Then this SLAM7, CD138, CD38, and GPRC5D. So currently approved and in trial bispecific antibodies. So BCMA antibodies, these are teclistamab and elranatamab. Then this is G protein coupled receptor family C group 5 member D. For these above two targets, the drugs are approved already. But for FC receptor homolog 5 and CD38 on plasma cells, these are the sites that are still being exploited in ongoing trials. So it is GPRC5D bispecific antibody. You can see there are two antigen binding sites, high affinity binding to GPRC5D on plasma cells, and other arm binds to CD3 on T cells. So what is GPRC5D? So it has a high expression on myeloma cells, which is also correlating with poor prognosis. They both, with BCMA, they both have a similar expression of CD38, 138 positive malignant plasma cell, and their expression patterns are independent of each other. So thereby, they offer distinct clinical targets for future therapies. The expression of GPRC5D is also not affected by BCMA loss, which can be seen in tumors who have relapsed after BCMA-directed therapy. So may have it this way, it may have a very important role when the patient relapses post BCMA-based therapy as well as CAR T-cell therapy. And what if we combine GPRC5D and BCMA? Maybe it is very well more effective too. So talquetamide, GPRC5D bispecific antibody, it is approved now, the only drug in this group. It was approved by FDA after this Monumental 1 trial. Post 4 lines of therapy, patients were taken. Median duration of response was 10.2%, and the overall response rates was 70%. Very impressive. Adverse effect associated with this type of drugs, CRS and ICANS, cytopenias, especially dysphagia and weight loss and skin changes are very well documented with this type of drug because the expression is also there on skin and related tissues.
Akash, your slides are
Another
not
part
moving.
that is important to understand in this discussion is CAR T-cell manufacturing gap that right now we are facing in our practice. So BCMA-directed CAR T-cell therapy requires 6 to 8 weeks manufacturing time, during which around 10 to 15% of patients experience disease progression or death. As we all know, these are heavily pretreated patients, and they respond very poorly to salvage regimens. And most of the time, we face that very high disease burden is there in at the time of CAR T-cell, so which affects the long-term outcomes. So effective bridging therapies is very much needed in this part. So for the residents, a little bit discussion of what is holding therapy and what is bridging therapy. So holding therapy is typically it's a temporary discontinuation or washout of specific myeloma treatment before leukapheresis. The purpose is that the T cells should recover uh, to recover from the suppressive effects of prior therapy. And there should not be a carryover effect of drug toxicity or interference with T cell functions. If you see the currently washout period observed and recommended is 1 week for IMiDs, proteasome inhibitors, 1 week, anti-CD38, mostly it is longer, 2 to 4 weeks, and alkylators against 2 to 3 weeks. What is bridging therapy? So bridging therapy is short-term disease control treatment administered between leukapheresis and CAR T-cell infusion. It can be around 3 to 6 weeks. Purpose is to prevent disease progression while waiting for CAR T's product availability and to manage symptoms or organ dysfunctions due to active disease. The whole idea is it should not impair CAR T-cell viability or expansion at the time of infusion. So now coming back to the study, aim of study was to evaluate the safety and efficacy of a short course of talquetamide as bridging therapy prior to standard of care, Idicel or Cilta-cel in patients with relapsed refractory multiple myeloma. Patient population, 20 centers across US and Germany. It's a retrospective study. All patients of relapsed refractory myeloma who underwent leukapheresis and received bridging therapy with talquetamide with the intention of receiving commercial Cilta-cel and Idicel were included in this study. Patients who received talquetamide as holding therapy prior to apheresis and then continued as bridging were also included. They defined high-risk cytogenetics as per INWG criteria, and patients with non-bone-based extramedullary disease were also taken. Outcomes. The primary outcome was safety, feasibility, and efficacy of talquetamide, bridging in patients with intention to receive Cilta-cel and Idicel. Safety outcomes, CRS, ICANS, talquetamide-related unique toxicity, delayed neurotoxicity, infections, secondary primary malignancies, and cytopenias. Efficacy outcomes were mostly response rates to talquetamide and CAR-T and OS and PFS, along with some non-relapse mortality. Other outcomes were CAR-T cell kinetics, and the plasma cells were also studied for quantification of soluble BCMA. So let us see what the results are. This study started with 134 patients. 19 received talquetamide before bridging therapy as a part of holding therapy. 115 received after leukapheresis. 15 patients, no CAR-T cell infusion could not be done. 7 because 7 had disease progression, 6 had manufacturing failure. So in total, 119 patients received CAR-T. Majority received cilta-cel, 98, 21 received AD-cell. If you see the baseline characteristics, 65 years is the median age. PS2 patients were also taken. 44% patient had high-risk cytogenetics. 41 had extramedullary disease. 10% patients received prior BCMA-targeted therapy. Prior lines of therapy median 5 and pentarefractory 34%. Most importantly, 85% of patients were there who were not meeting CARTITUDE-1 and KarMMa eligibility. So overall, this tells that a very bad prognostic subset was taken for this study. Talquetamide dosing, majority 82% received 0.8 milligram per kg subcutaneously every other week. Median time on talquetamide was 23 days, and the median time from last dose of talquetamide to CAR-T was 26 days as an washout period. The median number of talquetamide doses administered at 0.8 milligram per kg or equivalent was So the outcomes were of 134 patients receiving talquetamide, 89% successfully proceeded to CAR-T cell therapy. Only 15 could not. So these are the responses. As you can see, they are ongoing responses. More patients got into good responses after talquetamide. So 71% response post-talquetamide and 88% post-CAR-T. Among that, 54% were in CR. So response deepened in 42% of patients after CAR-T, demonstrating effective sequential targeting strategy. This is the survival curves, median follow-up 6.9 months. PFS and OS was not reached. By subgroups, none of the subgroups had any significantly different outcome. You can see rather EMD, extramedullary disease patients were doing badly. CAR-T cell expansion and soluble BCMA levels. CAR-T cell expansion kinetics were similar to previous studies, and soluble BCMA levels decreased significantly after exposure. So this is response to talquetamide and best response of CAR-T cell infusion by CAR-T cell products. It is very impressive, as you can see. And also here it is important to note that those patients who had a prior BCMA exposure, they had 78% response. However, who had no exposure, they had 95% responses. As far as safety profile is there, as expected, 73% CRS. ICANS were low, but there were 3 patients in talquetamide who developed ICANS, grade 3 and 4, and 1 in CAR-T. It is important to understand here that in this study, those patients who received, who developed CRS and ICANS on talquetamide also developed CRS and ICANS on CAR-T. Rather, few more patients added up in CAR-T during CAR-T infusion and in due course. Besides the class effect, the skin toxicity, nail toxicity, oral toxicity, weight loss, there were quite a few seen in talquetamide, but there were no alarming grade 3 or grade 4 toxicity. Infection rates were there, yes, 18% any grade, but then 5% only in grade 3 or 4. And there was one case of AML reported after cell-to-cell. Safety and efficacy across subgroups, it was not different, be it high-risk cytogenetic abnormality or extramedullary disease or prior BCMA therapy. If we see the talquetamide efficacy across the subgroups, again, it was not different in either subgroups. Neither was the incidence of CRS and ICANS. At the last follow-up, it is important to understand here, at the last follow-up, 40% of exposed patients had persistent toxicity, that is nail and taste related changes. So our findings suggest that talquetamide bridging is feasible, safe, and effective, enabling a majority of these difficult to treat patients to successfully receive BCMA CAR-T. Sequential treatment with talquetamide followed by BCMA CAR-T resulted in a sustained decline in soluble BCMA levels. And CAR-T expansion peaked around 14. The kinetics was consistent with previously published CAR-T expansion kinetics. So what are the implications on current myeloma therapy? Rapid disease bulking during manufacturing period reduces progression risk. Dual targeting may prevent antigen escape and enhance durability. Reduced soluble BCMA may overcome resistance pattern for resistance mechanism for BCMA CAR-T. And compared to BCMA, GPRC5D antigen loss appears to be more frequent, occurring in up to 100% of cases post-CAR-T and 50% post-talquetamide relapse. So the limitations, retrospective study, lack of comparator arm, and relatively short follow-up, responses to talquetamide were unconfirmed, and radiological responses were not systematically assessed in all patients according to IMWG criteria prior to CAR-T infusion. Value and current practice. So will it transform CAR-T cell access? Yes. Talquetamide bridging appears safe, feasible, and effective, enabling 89% of difficult to treat patients to successfully receive BCMA CAR-T therapy. But there are still questions unanswered. Can talquetamide may help GPRC5D positive and BCMA negative subclones prior to anti-BCMA CAR-T infusion, potentially mitigating the risk of antigen escape and relapse? We don't know. Whether a short course of talquetamide can induce GPRC5D antigen loss and subsequently impact the efficacy of future GPRC5D type 2 therapies, we don't know. Maybe future therapies will look into it and we'll have a better clarity on that. Thank you and Happy New Year.
So thank you, Akash, for the great presentation and nicely discussing the article. I think just taking it forward, what Dr. Akash left it at the point that why we have such kind of therapies are necessary for us, especially in the managing the relapsed and refractory multiple myeloma. Like we all have been, those who have been treating multiple myeloma after first or second line therapy, generally we end up into very kind of difficult situation that how to really handle these patients. And especially the kind of options which we have initially with the combinations of BRD, VCT or BTD, or now with the carfilzomib, which is available, so as a second line. So the first thing that those who have a long-term CR, especially following transplant, there it is much easier because you are able to give them the playing with these molecules. Generally the response are short-lasting, maybe 3 to 6 months or 9 months, and then you really become very kind of desperate situation now how to really get the myeloma under control. So that is one scenario. Secondly, like patients who have the high risk disease or a large burden of the disease, especially the extramedullary disease, it becomes kind of difficult. So in that sense, this is one of the uh, therapy, the bispecific antibody, which has opened the way that at least we are able to get those patients who have been the 3 lines or 4 lines or 5 lines of so-called resistant or refractory to those therapies, then at least one can try to use one of these. And now CAR T cells, though we still do not have easily available to all patients in India, but this is something which is now under the evolution. And hopefully in next couple of years, many more patients will be able to get the benefit of CAR T cells. Now, prior to going to CAR T cells, because obviously it takes little time, 4 to 6 weeks before they can go to CAR T cells. So you will like to really treat your patients with the, so get the disease under control and before they can go for CAR T cells. For any CAR T cells, whether we are using for leukemia, lymphoma, or now with myeloma, your disease has to be in remission or at least near remission so that you can expect the good outcome following the CAR T cells. So in that sense, the teclistamab and now talquetamab, so these are being used as a bridging therapy that you can bring the disease under control and then proceed for the CAR T cells. So in that context, this particular paper fills that gap that now you have the talquetamab also can be used as a bridging therapy for before proceeding to the CAR T cells. So the one of the issues has been that when we treat these patients with some of these bridging therapy, 10 to 15% of patients may not be able to really make it up to the CAR T cells because this the gap of 4 to 6 weeks, the disease may progress or they may have some untoward complications. So in that sense, what Dr. Akash highlighted from the present study, that this study really has, which is multicentric, so which is good in that sense, and almost 20 centers. And these were the patients who were heavily pretreated, and most of them had the high-risk disease. So in that context, you could 89% of patients could proceed to the CAR T cell therapy, which is a kind of very satisfying that at least this as a bridging therapy, this probably is very at least promising approach. And the other points which he highlighted were that the efficacy in almost nearly the 77% objective response rate, overall response rate, and the post-CAR T cell that you could achieve 88% response rate, including the 54% complete response, which is quite very promising. And then obviously is likely to translate into the long-term outcome. The other points which he highlighted that was that the toxicity, especially the CRS and the CANS, the grade 3 and grade 4 were very few. Mostly it was the grade 1 and grade 2. Though there have been some toxicity like the oral skin and the nail toxicity, but mostly these were the grade 1 and grade 2. So, and the peak CAR T cells were like on the day plus 14, they could undergo to this. And so this talquetamab did not impair the expansion of these CAR T cells. So that was another point, I think, which was made by him. So with this therapy, so now the most importantly, this is something which can be done on the outpatient basis. So it is not really required. Most of patients do not really need the inpatient's admission for this. So something which can be done in the low resource setting. So that is another thing. So especially like if we have patients who have cytopenias and who are heavily and huge burden of the disease, then this probably could be one of the important therapy which can be used. And so now the next question I think which will come like, so how does it compare with the chemotherapy which we have in our hands, like especially DCP or some of the similar kind of combinations for many of the patients, which when we don't have the access to that, then we normally go for this. or some of the centers, they, like for example, if I have a patient today here in Delhi, and then we want to send him for the CAR T cell therapy, which is going to take time. So like, how do we really manage them with Tecli or Telcutamab or with chemotherapy or simply steroids? So these are some of the questions which people want a little more clarity, how it can be done. So let me see this, if I can get my slides. I have 3 slides, which I just very quickly prepared. So I don't know how do I.
Yeah, we can allow sir to share the screen.
So
Yes, sir.
so how do I
You can share the screen, sir.
share the screen?
So at the bottom, there is a option of share. Just once you touch it, you'll get options there. Participants, chat, and then
So it's a green color button at the bottom.
Oh, okay. This one? No, this is not. So yes, share. Right.
Here and then sir double click your slides. PPT.
Okay. So yeah.
You got it?
So this is now here. Yeah. So this is actually
Yes,
just
sir.
I use this chat GPT, to be honest. That's how. So this just compares like the targets that in the Tecli and Telcutamab, and then the comparison with the chemotherapy and steroids, how this compares the bridging the speed of response, then the bridging efficacy. Obviously, with the chemotherapy, you have the response rates are generally, especially in the people who have been refractory, like 4 or 5 lines after the response may be little not so great. It will be like somewhere nearly 30 to 40% or 30 to 50%. And of course, you run the risk of severe cytopenias also. And the steroids again will have the modest effect. And the other things like this, so the impact on subsequent CAR T cell therapy, probably I would say that both Telcutamab and Teclistamab almost nearly similar kind of thing. So in that context, the chemotherapy probably does not really, I mean, so they both are superior compared to the chemotherapy in that sense. And among the common toxicities, which are also almost similar, parallel to both in Tecli and Telcutamab, except there's some toxicity with the Telcutamab of the oral and skin and the taste and the nail changes, which are not so common. While in Tecli, you have more of infections and cytopenias. While in chemotherapy, we all know that some myelosuppression infections and organ toxicity. While in the high dose steroids, sometimes some people have used in earlier days, the hyperglycemia infections, the associated problems which we have the high dose steroids. And both Telcutamab and Teclistamab, they are given subcutaneously, and both can be done on the outpatients. And generally, the period is like about roughly 3 weeks, 2 to 3 weeks, kind of which there. And the washout considerations, like in the Telcutamab, it's like 2 to 4 weeks before apheresis, and generally people like the 3 to 4 weeks before CAR T cell commonly, this is what being used. While in, so again, in the teclistamab, generally it's about 2 weeks, which most people use it. And so if we have somebody who is BCMA naive and there is large burden of disease, then probably talquetamab may have little an edge over the tecli in that sense. So coming back to the so I think the Dr. Akash highlighted that we really need to have the first thing that this particular study highlights that talquetamab is another agent which helps us to provide the an option that can be used for the bridging therapy, and obviously one need the prospective trials and see that these and then long-term follow-ups how this really stands and in the long run the efficacy and the durability of the CAR T cell response. That's what I would stop it here. Thank you.
Thank you, sir. Thanks a lot for the deliberation. Sir Pankaj sir, your inputs, please.
Professor Lalit has already, highlighted the, the implications of this study. I would only say that, probably the reason for doing this study was that CAR T is one-time kind of a therapy, whereas when you are using bispecifics, right now, currently people think that this is, kind of an indefinite form of therapy. So you really want to give one-time shot to the patient, and if the patient is is in CR or MRD negative state, then obviously he has, free drug-free holiday, and some of the patients we know are cured of the disease with one-time CAR T cell therapy. And when you are for the CAR T cell therapy, you really require a good T cell functions, and even for talquetamab also, actually, you require a good T cell functions. Whereas, the study was done in those patients who had a median number of therapies were around 4. That means they have already received the kind of a therapy which leads to quite a T cell dysfunction. And on top of that, if you are trying to treat an extramedullary disease, which is mostly with the chemotherapy regimens, then you are further deteriorating the T cell health. So probably that is one of the reason why talquetamab was used, because you are going to give a BCMA directed therapy, so you can't use teclistamab here. So you give so this basically not the trial, this retrospective study demonstrated that probably you can use talquetamab in this kind of a situation, and just the median dosages was just 2, which means probably 2 to 3 weeks of therapy, not 2 to 3 weeks. This is given every once in 2 weeks, so probably a month or 2 months of therapy, then followed by 1 shot, and then you are done with the patients. And kind of a response is really gratifying in this highly relapsed refractory kind of a patients, where 90%, 88% kind of overall response rates, and 54% are, I think, CR. So really gratifying. But obviously, you need to test all these things in a prospective manner. Only then, you can really say that this is the standard of therapy. But this is a good study to show that this is feasible. This is feasible. You can consider this form of therapy. Thank you.
Right. So another option actually. In this context, Pankaj, I would like just highlight here that I think recently Dr. Saji Kumar has published a paper in the New England Journal of Medicine. They have used both teclistamab and talquetamab for the extramedullary disease. So the patients who have got the huge burden of disease, and if you combine, and they've been able to show that in almost, I think, nearly, if I remember correctly, nearly 45% of something patient who had a long-term benefit with that. So that is a very interesting paper, because the extramedullary disease always has been one of the very difficult area for the treatment of especially myeloma, especially after the multiple lines of therapy. When they have the visceral involvement and all that, really nothing at least works. So in that
So,
context, like
yeah.
combining both of them would be something.
So the field is evolving so rapidly, and in the recent ASH there was a breaking abstract on the in vivo CAR T cell therapy. So in future, they have demonstrated that in vivo CAR T cell is possible. So in future, possibly you don't need to take out do the leukapheresis and send the T cells for manufacturing. You just give the lentivirus, and your body will make the CAR T, and the whole scenario will change. So people are looking forward for in vivo CAR T cell therapy, and they did in 4 patients only, but all the 4 patients responded very well, and 2 are in MRD negative state. So that was a late breaking abstract in the ASH this year. So the field is evolving very fast, and newer therapies like bispecifics and trispecifics and in vivo and other CAR T, allogenic CAR T are really changing the landscape of treatment of multiple myeloma very fast. Thank you.
Uday, I would like to ask you here, like I think you have compiled some data on the teclistamab experience in India.
Yes, sir. So, sir, like
Would you
all
like
of us
to say?
together, we have put the data together. So
Okay,
we
so
have
would you
around
like to make
100
some
patients
comments
data.
about that? Like what
So
is the long-term outcome, the relapse rate, and the infections rate, and the like morbidity and mortality? Any comments you'd like to say? A few lines
Sir,
on that?
so we are in the process of still formally analyzing it, but
Okay.
broadly, to answer your points, so the median duration of teclistamab that the Indian patients have received is 3.9 months. This was the reason for such short median duration was one, mainly financial. Second, because of giving teclistamab at a very late stage of the disease. So many patients are succumbing to the illness because of giving teclistamab might be slightly later in the course of the disease or till the time they arrange their finances. And out of the patients who have received, the success rate in our country is not beyond 60%. So again, this is probably because of the heavy baseline disease that at which teclistamab is introduced. So maybe with more education and more awareness among the physicians in the country, if we can actually start giving teclistamab earlier in a relapse refractory state, then probably our results would be much different. Also, we have had bad infections, though surprisingly not tuberculosis or bacterial infections. It's primarily the viral infections, which is the cause of death in our patient cohort. So,
right. Recently, there was also a paper actually, which is just in front of me, and this is published from the Blood Cancer Journal. And this is the outcome of relapse after teclistamab therapy in multiple myeloma. So the people this is like kind of there are multiple centers in the US, and they just compiled the data of nearly more than 100 patients. And the objective response rate was 65%, 64.8%. And the 1 year overall survival was nearly 70%. And the PFS of 9.8 months. This is what it says. And those who relapse, for them, the median survival was like roughly nearly about 6 months, which probably is understood because by the time the people go for teclistamab, even in US, maybe after 3 or 4 lines or 5 lines of therapy, so they already kind of become the T cells are exhausted and more prone for infections and really not able to tolerate. So that is the kind of thing. Recently, I just saw one patient who was treated by us for transplant long back, and then he had relapsed, and then he was from Maharashtra. So he got teclistamab in one of the center, probably in the clinical trial, which is I think phase 4, which is going on multiple centers. So he got really about 3 months, but then he progressed and then he came to me. So it was amazing. I mean, the whole body was riddled in the sense so much of visceral involvement I have never seen in my life. I mean, so pictures, the kind of the liver, lung, everywhere, the skin. I mean, he had the bone was totally packed, severe cytopenias, and he was trying to manage with the kind of platelet support almost twice a week and all that. And then finally, he succumbed just 3-4 days before. So some of those patients, but probably then, as you said rightly, that maybe if we have to introduce them, we should introduce them early. And also we need to really identify the patients, the kind of they are coming from which background, whether they can manage infections timely, or they can come to the center for the management of infections. So careful, I mean, keeping them into the close observation is something which very, very important, I would say.
Are there any questions from the audience, Uday?
No, sir, done, sir. None as of now. And if at all, if you permit, sir, both of you, so then we'd move on to the general scan, which is again the article by Lalit sir only and his team. So over to Sumit for the general scan article.
Good evening, sir. Are my slides visible?
Yeah,
Am I audible?
Yes, slides are visible, sir.
Okay. So good evening, everyone. So for the month of December 2025, the journal scan article chosen was Management of Relapsed Refractory Myeloma in the Resource Constraint Setting from Lalit sir's group. And it's a study of more than 400 patients and probably the largest data set from India of relapsed refractory myeloma. So just to give a brief overview of the process for those who are new to this, a recently published article on plasma cell dyscrasia is chosen. We invite a commentary of 175 words before a deadline. Irrespective of designation, anybody can send this commentary who has an interest in the field of plasma cell dyscrasias. The best commentary is chosen by a team of blinded reviewers. And the gain is he or she gets a chance to present a journal scan in front of the August audience, get a certificate, image credit hours, and lifetime membership. So the intent is that our young faculty and students should read the latest article on plasma cell dyscrasias, learn the art of critical appraisal, refine the art of scanning an article, and this will hopefully encourage more letter to editors from our country, and at the same time get an opportunity to present in front of a great audience. So the winner for best commentary for this month is Dr. Sneh Bhargave. I hope I'm pronouncing the name correctly.
yeah.
She is currently an assistant professor in medical oncology at Central Armed Police Forces of Institute of Medical Sciences, which is a collaboration with AIIMS. And she's an assistant professor in medical oncology from there. And it was a very well written commentary by her. Congratulations to you. I hereby request my studies team to play the recorded commentary.
Good evening, everyone. I am Dr. Sneh Bhargava, Assistant Professor Medical Oncology at CAPFIMS. Today, I am presenting a critical real-world study from AIIMS Delhi on management of relapsed and refractory multiple myeloma in resource-constrained setting. It addresses one of the most challenging clinical scenarios we face in developing countries, that how do we manage relapsed and refractory myeloma with limited resources. Before we dive into the data, let me establish why this matters. Multiple myeloma is the third most common hematological malignancy globally. In developed countries, patients enjoy a median survival of 7 to 10 years due to novel agents. With successive relapse, we see survival shrinking from 9.2 months down to 5.6 months in patients with pentarefractory disease. In resource-limited settings, median survival is much shorter because of late diagnosis, limited access to novel agents, limited sources for supportive care, high patient burden from infections, lack of prognostic tool like cytogenetics. This study gives us real data on what we can achieve in settings like ours. Let's look at the study design. This was a 5-year retrospective analysis conducted from 2014 to 2019 at AIIMS New Delhi. They registered 700 multiple myeloma patients. Of these, 534 were evaluable for analysis. After excluding 132 who underwent stem cell transplantation, final cohort for this relapse analysis included 402 non-transplant patients. The primary endpoint of the study was progression-free survival after salvage therapy, what we call PFS2. Secondary endpoints included overall survival, response rate, and adverse events. Why we focus on this? Because this is a real-world scenario we face patients with limited transplant access who need salvage therapy when they relapse. Now let's look at the baseline characteristics. This tells us what kind of patients we are dealing with. Median age was 59.5 years. About 2/3 were male, that's younger than typical Western myeloma population. But here is what is striking. 61.7% were ISS stage 3 at diagnosis, very high risk disease, either due to late diagnosis or bad biology. Looking at the organ involvement, 80.6% had lytic bone lesion, 65.4% had anemia, and 33% had renal impairment. High serum LDH and low platelet counts were present in 10.9% and 11.2% of patients. Only 26% had cytogenetics available. That means 74% had no genetic risk stratification, a major limitation but also a reflection of LMIC reality where FISH testing is not universally accessible. Over time, 69.4% of the original cohort experienced progression. This is the unfortunate natural history of multiple myeloma, but all relapses are not the same. Among those who progressed, we see three distinct patterns. First, 55% main treatment cohort had symptomatic relapse. Second, 21% had asymptomatic biochemical relapse. These patients were observed closely without immediate treatment. Third, 8.2% died before they even relapsed. That emphasizes how aggressive this disease is. This is a breakdown of response rates after induction therapy. 92% achieved overall response rate after induction therapy. Now, among the 195 symptomatic patients who received salvage therapy, 176 were evaluable for response. They saw 10.8% achieved complete response, 7.9% achieved VGPR, 36.9% achieved partial response, but 25% had progressive disease. Then they analyzed progression-free survival after salvage therapy, which was stratified by response achieved. Here is what they found. Median OS was not reached at a median follow-up of 31.8 months. PFS2 was 31.2 months in patient who achieved CR versus 8.2 months in less than CR, as you can see in Kaplan-Meier curve, where the curves are beautifully separated. On the other hand, there was no significant difference in progression-free survival by pattern of relapse, biochemical or clinical, in second curve where the curves are almost overlapping. They also stratified response by drug refractoriness. Patient whose disease was refractory to prior therapy, meaning they never responded or progressed within 60 days, had a decimal PFS of only 5 months. In contrast, patient with non-refractory disease who achieved PFS of 11 months. Circulating plasma cell more than 5%, platelet count less than 1 lakh, and ISS3 were associated with poor outcome. From the safety point, the most common grade 3-4 adverse event was anemia at 7.5%, followed by thrombocytopenia at 5.7%. Treatment discontinuation occurred in only 2.4% of patients because of neuropathy. In total of 124 patients had died. Most common cause of death was sepsis, followed by pneumonia. CR is paramount. We must push hard for complete response in salvage therapy. It's not enough to get a partial response. Wait and watch is justified. 21.8% asymptomatic biochemical relapse safely observed. No immediate progression to symptomatic disease during study period, so we can delay expensive salvage therapy while carefully monitoring. This study provides real-world validation for this cost-effective strategy. Drug refractoriness to dual therapy containing IMiD and proteasome inhibitor is associated with poor outcome. Circulating plasma cell of more than or equal to 5% is a critical marker. LMIC specific insight. Real-world data validates triplet-based salvage despite limited access to monoclonal antibodies. Here is a critical finding. No single regimen was statistically superior when they compared different salvage regimens. So the specific drug mattered less than the achieving deeper responses. This study has some critical clinical gaps despite the wonderful real-world data which it provides. This is real-world LMIC data generalizable to developing countries with comprehensive outcome with adequate follow-up. Limitation of the study. It's a retrospective single-center design which carries selection bias. Most importantly, no monoclonal antibodies were available during the study period. This underestimates what is achievable in the modern era. Let me dissect through the area of clinical gaps and future direction. Monoclonal antibody accessibility leads to survival gain but is cost prohibitive in LMIC. Incomplete cytogenetics led to missed opportunities for risk-adapted strategies in modern era. 21.8% asymptomatic biochemical relapse observed conservatively, but it needs prospective validation. Maintenance post-salvage remain unexplored. LMIC urgently needs cost-effective analysis to optimize resource allocation. Future directions. Biomarker-driven treatment personalization strategies are needed. It would be enlightening to see the prospective evaluation of wait and watch timing in biochemical relapse. We need to develop an indigenous and cost-effective card for pentarefractory cases. Despite all limitations, the study provides three important messages. Aggressive salvage therapy must target CR, VGPR in symptomatic relapse and refractory myeloma. Conservative observation is acceptable for asymptomatic biochemical relapse. Meaningful outcomes are possible in LMIC setting with smart evidence-based strategies. Thank you.
Thanks a lot for the general scan presentation. We will take some comments from Lalitsa because he's here. But before that, I would like to just share upon the screen for the quiz QR code, because in the meantime, the people can keep joining the QR code, and we will have the comments from the Lalitsa. So I request all the audience to kindly scan the QR code. We are going to have very simple 5 questions from what has been presented till now and has been elaborated by the experts today. So can I request everyone to kindly click on the QR code, and or you can just enter your browser section and put slido.com and put this hashtag 389378. Either of the options, whichever suits. And there is no embargo upon who can join. Everyone can join. Anyone who is listening can join. So we wait for the people to join. In the meantime, I would request Lalit sir for his comments, please, on the Journal Scan article, sir. Sir, give us some insights of what is not written in the article. So, because every article has a backstage story. So if you could just elaborate on the backstage story of this article as well, please.
Thank you there for choosing this article, and thank you, Dr. Sneh. She's done a very nice job, actually, very nicely summarized the whole thing and put her perspective. So I really appreciate. I think Dr. Rohit Reddy, who did the DM with us, it was part of his thesis analysis, and he did a very good job. Very, very hardworking boy, I must appreciate, and very, very nice person. And he really went to all the records, for almost sitting in the record room and going through it, calling the patients on telephone, asking their follow-ups and other things. So the good part of this study was that we really had a follow-up nearly more than 80% of patients where we have the total complete details. I mean, so that was one of the, I would say, because of the hard work put on by the Rohit, so we could get information about their whereabouts and other things. The other thing I would say that this actually gave us little, we had actually, there were 2 parts of the thesis. One was the non-transplant patient and another the transplant patient. Transplant patient, since we had some more follow-up, and I had kept that database of transplant also with me. So we thought we will probably add some more patients and follow-ups little more. And because the Rohit has left actually after passing his DM, so there was little, and then I also moved from AIMS after my retirement. So somehow there were little delay. That's why this paper we wrote a little late. Maybe could have been a little more even relevant, maybe 5 years back when all these things were not available. But what I would say that this was actually which was possible and we could do in the clinics. We could not do many of these things in a systematic or organized way, like that, having a protocols for relapse refractory, the first line, second line, or third line. That is something which I realized that we should have been doing it. But it was whatever was available and whatever was given to them, then we just analyze the data and then we put that into the. So it was all Rohit and the hard work in that sense. Secondly, the daratumumab we did not really had at that time. Later on, some patient who survived, who responded, we got for about nearly 10 patients who could get the daratumumab, but they were not included in that during that period of the thesis when it was analyzed. This was much later, which has given as a part of the phase 4 trials. So we had the access to the about 10 patients daratumumab, and at least 2 or 3, I remember they really benefited in the sense that they gave them another long-term remission for nearly about 9 to 12 months before they had another relapse. So which at least then, and in fact, in that paper, in the last, we have also given the Sankey chart, which the reviewer asked us that what were the therapy given to them after the relapse, and they have responded. So then we again went through the whole database, and we found like what were the second line, third line. So maybe distinctly, I can give you like data on like 4 or 5 patients. So we had about 3 patients who went on teclistamab. These both, all 3 are still alive and they are doing okay. And one of them is now nearly close to 2.5 years. This is much later actually. Uh, and as I think, and of course, the many patients they got the daratumab, which was available or in the market, or they could afford it subsequently. So some of that they also got benefited. So, so we had actually quite a stable response or long-term response in the patients who had initial CR, and then they continued for long-term in remission, then relapsed, and then giving the second line or third line, they again had the long-term outcome. So that what Sneh highlighted, that having the initial good response is always the key of success. So giving the adequate primary first line therapy, the induction therapy, the proper dosage and other things, that I think really makes a lot of difference. And over the years, I have seen that the transplant in the patients, we should be putting them like in trying to convince them to go for the transplant, because those who have responded to the initial induction, BGPR or CR, then consolidating by transplant, especially in our setting, gives you really next 5 to 6 years or even longer. And they really, they're huge difference, people who have undergone transplant versus those who have not undergone transplant. So the limitation, I feel that some of the toxicity, many of the patients who have died at home, so we have not been able to record them carefully, like what was the cause of death and all that. Some patients who survived, few of the patients we lost during the COVID time, and there are occasional patients who died due to the dengue fever.
So,
There were only 1 or 2, like those viral dengue, but their myeloma was in remission at that point of time. So these were some of the points. So that was probably, I would say, one of the major limitation of the complete toxicity was not, we do not have the data on the complete record of the toxicity, the kind of infections and other things.
thank you. Thank you, sir. Thanks for those
Right.
insights. So
Right.
with that, we will proceed with the quiz. We are going to have 5 questions on the 2 articles that we have discussed till now. So are we ready for the quiz? So I request all of you to get onto your keypads. It's the fastest finger first. So it's not only the right answer, but also what we are looking at is how fast can you answer the question is matters the most. So with that, here comes the first question on your screen. What was the most common oral toxicity associated with talquetamab bridging therapy? Okay, so most of you have got it right. So it's dysgeusia, which happens with talquetamab, which I believe is very debilitating and patients really complain quite a bit. So this is one complication which most of the international papers talk about. So we really do not have much experience other than the 2 trials which are going in the country wherein only 8 patients have been included. So this is something which is a common toxicity with talquetamab. With that, let's get on to the next question. So, okay, we have the leaderboard here. So Shikha is first. So let's go ahead with the next question. What percentage of patients receiving talquetamab experience CRS in this particular cohort? This is based on the first paper that was presented today. Good. Again, most of you have got it right. So why I had put this question is to drive home the point that even with talquetamab and in those patients who are heavily treated and have a high burden of disease, when you are giving bridging, CRS still remains one of the common complications. In fact, the teclistamab has also reported somewhere close to 80 to 85% in those initial trials. So talquetamab, 73% of the patients have reported high CRS or some form of CRS in these patients. So with that, let's look at the leaderboard after the second question. Okay, so this is the leaderboard after the second question. Let's move on to the third question. In the relapsed refractory myeloma study from India by AIMS, what was the most common grade 3 or grade 4 hematological toxicity which was reported? Good. People have been very attentive today. So yes, you are right. So thrombocytopenia was the commonest grade 3, grade 4 hematological toxicity which was reported in this study. So the reason of putting this question is to make everyone aware that this is something which you need to keep your eye on when treating relapsed refractory myelomas, because the type of high dose chemotherapies that we use and the agents that we use, this is a common complication. But please also understand, as Lalitha just elaborated upon, Delhi happens to be a hub for dengue infections, and probably some patients would have also have had other causes for thrombocytopenia other than myeloma per se or the drug-related thrombocytopenia. So that's the next question. So okay, we still have Shikha leading the leaderboard. The next question, which of the following was a significant predictor of inferior PFS2 in relapsed refractory myeloma patients in this study from AIMS by Lalit sir? Nice. So that's the circulating plasma cells, more than 5%, more than or equal to 5%. This was also highlighted by the presenter. So this was one of those important predictors for inferior PFS2 in this RRMM patients. So circulating plasma cells is extremely important. In fact, now TMH is working extensively on the peripheral MRD or circulating tumor cells as one of the indicators for prognosis, not only in relapse setting, but also in the upfront settings and for using it as a surrogate for bone marrow MRD. So with that, let's come to the last question. Who is leading the path? Okay, still Shikha is there on the top and followed by Aditya from PGI. So the last question for the day. Which factor was significantly associated with inferior PFS and OS after CAR-T talquetamab bridging therapy? This was based on the first trial or the first study which was presented. And this was elaborated by both the national experts extensively. Yes, most of you are right. So that is the extramedullary disease. So this is something which all the myeloma physicians or the dysproteinemia physicians are really scared about, of presence of EMD. That's something which actually puts the patient's prognosis on the downward side. So that's where we are. And with that, let's look at the final results for the day. So we have Shikha who won it. So Shikha, heartiest congratulations. She is from Army Hospital RNR. And followed by that, we have Grishma and then Aditya in the screen, followed by Dr. Naveen Bhati and NM. I'm not sure who it is. So with that, I congratulate the winner and we would be mailing you about the prizes for this. And Shikha, you have won it in the past. So we would be giving you an International Myeloma Society 1 year fellowship or 1 year membership free as part of the winning for winning this quiz. So with that, I would like to stop sharing my screen and hand over the stage back to Sumit for announcing next year's next year's Journal Club Journal Scan.
Is my slide visible?
Yes, dear.
Okay. Thank you there, sir. So next year and next month, the Journal Club article is teclistamab plus daratumab relapsed for refractory multiple myeloma, published early part of this month itself. And since bispecific is the flavor of the season or the year, what do you call it, in myeloma? And this article has made many headlines. In fact, has crashed many old papers also. It is very relevant to discussion. So this is a Journal Club article for next month, 22nd January 2026. The journal scan article is optimizing lenalidomide therapy in renal impairment, analysis of renal response in the prospective remnant study in transplant eligible newly diagnosed multiple myeloma. This is from the Nordic Myeloma Group, published early this month again. Now, this is very relevant to our setting also, because in renal impairment, what len dose do you give or not to give is relevant, and it is practically also important. So we already finished the quiz. So I would request Dr. Uday sir to give the vote of thanks.
No, we have Pankaj sir here, so I would like to hand over the stage to my past president and dear mentor to wish everyone a happy new year and also to close the session. Over to you, Pankaj sir.
You can do that. And anyway, thank you so much, the presenter, Dr. Akash, and Dr. Sneh for the journal club and journal watch, and Uday for the online quiz, which is very interesting, and Sumit for organizing all this and including selection of the articles for the future journal clubs. And thank you all the participants. You have all been wonderful. Supporting this myeloma journal club for the last 3 years now in a row. And I think the number of participants are going up in each journal club, and we have international students also who are participating in that. We would actually like the international students, faculty, or colleagues who can participate in the journal watch also, as well as in the quiz also. And I think next year we are going to do some changes in our journal club, in the sense that we are going to invite the SAARC countries myeloma experts who can give their comments and discuss about the relevance of those journal articles in their setting. With that, I thank you very much, and special thanks to Dr. Lalit Kumar, who was as national expert in both the journal club as well as in the journal watch. Thank you very much. Merry Christmas again, and Happy New Year to everybody. Thank you.
Thank you all. Thank you so much.
Thank you, sir. Jai Hind.
Well, Jai.
Jai Hind.
And many thanks to for doing this so vibrantly. Very impressive.
Thank you. Thank you, sir.
Right. Right. It's great.